Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. And welcome back to another Computer Connect. The conversation I'd like to have with you today is really about endoscopic colonic tattooing. This is something that came up in a conversation I had recently with one of my partners, younger partners, and I was complimenting him on his endoscopic tattooing technique where he put the needle in, lifted the mucosa up, and then injected carefully to make sure you get that submucosal dissection for the distribution of the India ink tattoo. But we've really not had expert guidelines or recommendations for technique until now, and a recent Delphi consensus conference really gives us a wonderful remedy to really provide expert guidance. This comes from a consensus group of 29 experts across the globe, from the Asian Pacific to Europe to the United States, well represented, looking at the identification of consensus recommendations through a Delphi process that were hammered down so they ultimately could allow 15 of their discussions to really have strong recommendations for at least the best practice by consensus. So where do we look at this? First, looking at the endoscopic contraindications. So contraindications for tattooing were two. One is cecal injection. Not needed. You have the ileocecal valve and the appendiceal orifice well identified, photographed, and no reason to risk transmural injection as it relates to the India ink. Again, not necessary, not in the cecum. The second is in the rectum. There is a relative theoretic risk of at least a mesorectal spilling of the tattooing. This is something you don't need to run the risk for inflammation or the fibrosis that's evident with India ink, much less the infection risk. This may be somewhat complicating to a transanal resection or an endoscopic resection. Again, it's very easy in the rectum to document distance from the anal verge. So looking at that as a documentation point, photo documentation, not needed, at least as far as standard recommendations in the rectum. The next was the indications for tattooing, and the first was in the case of an endoscopic diagnosis of a deep invasive cancer. So here we're talking about a Kudo 5 or a nice 3 pattern. We're not going to attempt endoscopic resection, but we're going to refer this to a patient, to a surgeon. Again, the idea here is to document for the surgeon, but the technique difference that you may not be doing is to do the injection before you do the biopsy. The concern is an inadvertent contamination of the needle with malignant cells via the biopsy channel, and then subsequently injection of the cancer inoculation to another colonic site or into the abdominal cavity. So again, do your injection before your biopsies in these patients that are going to be referred to surgery. We'll talk a bit about the technique of that in a second. The second indication is in those patients that after an endoscopic resection, and with at least a suspicion of submucosal invasion. So if that's the case, circumferential tattooing is recommended, and we'll talk about the technique a bit, but nonetheless, circumferential in patients that have a suspect for submucosal injection, submucosal invasion. The next is in the patients that have a lesion left in situ, suitable for endoscopic resection, now to be referred to another endoscopist. So whereas injection of these India ink compounds are really very sterile, rare complications, particularly related to transmural injection, can occur. So unnecessary tattooing is really the recommendation from the experts here. And again, a reasonable tattoo in one place, not circumferentially, but avoiding the over delivery of the tattoo. And the fourth indication is in the resected polyp that needs further surveillance. So here you've got an endoscopic resection, and again, a tattoo should be placed in those so to ensure where the scar is or where the monitoring really should be focused. But the tattoo again should be placed in that patient upon the completeness of the resection. So we'll talk about the technique here in a second because the authors go into that. So the next is the technique, which is really important. How do we do this? Well, one is that the easy to do is to place a saline bleb, and the authors endorse this. If you're not regularly doing endoscopic tattooing, colonic tattooing, it's a technique that's very easy. It's a tangential injection into the mucosa with saline. And then once you have that little mucosal bleb, injecting that bleb with the India ink, it's a very easy way to get in the submucosal layer before tattooing. And so again, that was a strong recommendation to consider that depending on your expertise. The tattoo should never be injected directly into the lesion or adjacent to the lesion, because this, again, the dispersion of the India ink is hard to predict, and endoscopically this may be a bit of a problem if you have that submucosal fibrosis develop as a result of the injection. So again, avoiding direct injection, again, avoiding deep transmural injection, fewer errors in localization, and use a saline bleb, which is something that if you have a difficult position or something that you really are concerned about, try the saline bleb first. The authors also recommend keeping the maximum volume to a cc, not to over-inject. Again, there's no reason to have a large volume injection at any one of the injection sites. Next is the localization of the lesion and the tattoo positioning. Again, 3 to 5 centimeters distal, that's relative to the anus, closer to the anal side. And again, if you're going to refer to surgery, 2 to 3 tattoos. If it's going to be just a localization for an in situ lesion left, or a post-endoscopic resection to monitor where they go, only 1 tattoo is generally needed. So again, the concept is minimization of the tattoo, recognizing that they're safe but not absolute. And then the final is the documentation of the tattooing. Again, recognizing in the report, clearly documenting where it is, distance away, and photo documentation is really important. Again, standardization of technique in an individual institution is really important as well. So new guidance, I think, really unifies the science around the endoscopic tattooing, something that we rely on, and I think we can do a better job. This expert Delphi consensus certainly gives us wonderful recommendations. Again, I think we can all do better. Please look at this document, listen to the recommendations, and let's unify how we best deliver this process. Dr. Dave Johnson, again, I'll look forward to seeing you again soon. Thanks again for listening.